Good afternoon, wherever you are. Hi, everyone, and welcome to another Health for the World Grand Rounds. Today, it's with great pleasure that I extend a warm welcome to Dr. Sayna Norouzi, who's joining us today. Dr. Norouzi brings a wealth of expertise and knowledge in the field of nephrology, with a specific focus today on IgA nephropathy. We are honored to have her here to share her insights and expertise with us. Dr. Norouzi has established herself as a leading figure in the study and treatment of renal disorders. At Loma Health, she plays a vital role in advancing patient care and conducting groundbreaking research, as well as educating the next generation of healthcare professionals. Dr. Norouzi's educational background is equally impressive. She completed her medical degree at Tehran University of Medical Sciences School of Medicine, where she excelled in her studies and demonstrated an exceptional dedication and passion for medicine. Following her graduation, Dr. Norouzi completed an internal medicine residency at St. Louis University School of Medicine, honing her skills and acquiring a deep understanding of renal diseases. Subsequently, she pursued an advanced fellowship training in nephrology from Baylor College of Medicine. Through her invaluable insights and vast experiences, we hope to gain a deeper understanding of IgA nephropathy and explore potential avenues to improve our patient outcomes. Please join me in giving a warm welcome to Dr. Norouzi as we discuss IgA nephropathy.
Well, thank you so much for the kind introduction, and hello everyone. I'm really excited to be here. The topic that we are going to talk today about, like IgA nephropathy, is really close to my heart. I have a glomerular disease clinic here that I started 2 years ago, and I see a lot of IgA patients here. So I really think this topic is important, and if we know what we are dealing with, and if we can start our patients on treatment as soon as possible, we can save many, many lives, we can save many kidneys, and we can prevent dialysis. With that, I'm going to start our lecture today. So this is my outline. I'm going to talk about IgA nephropathy disease history, and then I'm going to talk about, again, etiologies. I'm going to give you some time to ask me questions about these two topics in between, and then we're going to talk about treatment options, and then after that, we're going to wrap up. So I'm going to start with some facts about IgA epidemiology. So you know that we diagnose IgA nephropathy based on a kidney biopsy. So the fact that the diagnosis is based on a procedure, then the having access to kidney biopsy, it becomes really important. So access to kidney biopsy often associated with higher socioeconomic class countries and population, which is really unfortunate. The fact that having access to kidney biopsy is not that easy was happening here as well, which is on the east side of Los Angeles. So when I joined here, a lot of patients, they didn't have access to glomerular diseases clinic. And that means that having an access to kidney biopsy was kind of challenging for them, because they had to deal with seeing a lot of doctors in order to get to that point that someone can order a kidney biopsy for them. And even after ordering that, it was a long process to get to the procedure. So I think like the prevalence is underrepresented and in developing countries, and especially in areas that we don't have a specific GN clinic, and the populations that have less access to healthcare, of course. And in general, the incidence is often higher in children and young adults and in the elderly, but this may be due to screening of UA carried out in most commonly in these populations. So the thing is that you have to see the hematuria, you have to see the blood in the urine to get suspicious about something like IgA nephropathy, right? So everything starts with the screening. Everything starts with someone at somewhere sees this patient and feels like, okay, let me check a UA because the creatinine has been up. This is a young patient, or this is a very old patient, and I want to see what's going on. So everything starts with that starting point of getting a urine analysis when it's needed. This is the incidence of IgA nephropathy throughout the world. As we said, the numbers that we have about the prevalence of IgAN at this point, it's relative, and it's depending on how many kidney biopsies you order and how much screening you're doing. And if someone comes to you and say that I have hematuria, how seriously you take that. So these numbers can change if our practice changes throughout the world. Like, I'm not sure, for example, in Asian population, it's really common to say that IgA nephropathy is more common in the Asian population, but there are some hypotheses that they say that maybe it's because they have a different kind of routine for their follow-ups. They order more UAs and they pick up more hematurias, which leads to more kidney biopsies. So we talked about the socioeconomic status. I want to give you some more numbers about the prevalence and the prognosis of IgA nephropathy. So in our minds, when we are reading textbooks, we always feel like, well, IgA nephropathy is benign. So a lot of doctors, a lot of even nephrologists here around this area, they feel like I don't have to do much for IgA nephropathy because it's not as aggressive as vasculitis. It's not as aggressive as lupus nephritis. But if you look at the research, 20 to 25% of patients with IgA nephropathy, they end up on dialysis. So they become ESRD, end-stage kidney disease, just because they didn't receive enough treatment in the initial steps of the disease. And 20 to 30% of IgAN disease, they, as we said, within the 25 years, they end up on ESRD, which is not something that we said that, oh, in 25 years, that's a long time. It's, for example, if you're diagnosing a patient in their 20s and you follow these patients for years, and then you know that 30%, there is a risk that they're going to go on dialysis in 25 years. It means that when they are in their 40s and 50s, they are a dialysis patient. And that's a huge change. Like in your 40s and 50s, you're still young, you're still working, you still might have young children as well. You don't want to go on dialysis. You don't want to go under transplant surgery because it's going to affect your life and it's going to be a huge change in your life. So when we say that it's benign, comparing to vasculitis, yes, you're not going to probably, and there are some cases that they are aggressive, they become kind of a vasculitis, and you can lose your kidneys actually within a year or so. But usually in the setting of IgA nephropathy, it's a long process. But still, when it's happening, you're young and you're not ready to be a dialysis patient. And as we know, IgA nephropathy is considered the most common type of primary GN. So we are going to deal with IgA nephropathy as a physician throughout your practice. And the more you are more comfortable dealing with IgA nephropathy, as I said, more kidneys you can save and you can affect more lives. And with a lot of treatment options that we have right now, it's really important to understand the physiology and be able to diagnose IgA nephropathy as soon as possible. Now I want to talk about the IgA nephropathy etiology. It's such an interesting physiology, and a lot of clinical trials are ongoing because now we have a better understanding of how IgA nephropathy is happening in our patients. I'm going to make it really simple here based on this algorithm. Well, you know that we always hear that IgA nephropathy usually starts after contracting a viral or bacterial infection. That means that your immune system is already active and they are trying to eliminate that kind of a bacteria or virus that you contracted. But for some reason, there is going to be a defect in the mucosal immune system that we don't know exactly why some people, they have this defect, which could be genetic, or it could be happening throughout the process that your immune system is just overactivated and they're trying to fight with that virus or bacteria. And then you're going to have increased production of IgA1, which in your bone marrow, which is not the normal type of IgA that you have. This IgA1 that you have in the setting of IgA nephropathy is galactose deficient. So not only that you have this defect in your mucosa of your immune system, you are producing a kind of IgA that usually you don't produce. So your immune system is activated. You need to produce IgA because you want to deal with this virus and bacteria. But then the amount of IgA that you're making, part of that is not normal. It's just galactose, it's galactose deficient IgA. So your body doesn't like it, right? And they try to eliminate this extra IgA that you have because it's just not normal. So you're going to have this kind of production of cytokines and your activation, and it's going to activate your immune system to remove this kind of galactose deficient IgA as well. So now I'm going to talk about the forehead hypothesis. Now we know, like in a simple way, that what happens in the setting of IgA, there is this really common hypothesis that is called forehead hypothesis, that we believe that it's the main reason, that's the main physiology for IgA nephropathy. What happens is that, as I said, it's going to have the increased circulating levels of galactose deficient IgA. As we said, we don't know exactly why. Maybe genetic, maybe we are having some issues in our enzymes. Maybe it's just because your immune system is very, very activated at that time. So you're just having the mistrafficking of B cells from the mucosal area of your GI system and your immune system. You're going to have the increased production of anti-IgA1 antibodies. As I said, your immune system is not going to accept this type of galactose deficient IgA. So you're going to try to remove this type of IgA from your body as well. How does that happen? You're going to produce a lot of anti-IgA1, and it's going to be either IgA or IgG. So in the setting of IgA nephropathy, your IgG could be on the higher side as well, and you're going to produce a lot of IgA. That's obvious. Again, at this point, we said that everything probably genetic, maybe the type of viral infection that you're dealing with, maybe the type of strep antigens that you are producing because of the strep infection that you're dealing with. Maybe these are the reasons that you are having this fight inside your body against your immune system. And maybe that's the reason that everything has started, but we're not sure about that. The main fact that we know that there is a fight in our body against a type of IgA that your immune system produced. And this type of IgA is not the normal type of IgA that your immune system make. It's a galactose deficient IgA. So this antibody and this antigen, they're going to combine together. They're going to, because the antibody is going to go after the this antigen, and they're going to try to catch them, and they're going to try to remove them. So they're going to catch each other, and they're going to bind, and they're going to make an immune complex. So this immune complex is something extra in your body that now we have to remove it, and we don't know what to do with it, right? This is an extra product in your body that now wants to go and sit somewhere because it's just circulating in your blood, and it's an extra thing. And unless it sits somewhere, your immune system is going to try to remove it from the blood, right? So the immune complexes are going to come and sit on your kidneys, probably because we have a special receptors for this kind of immune complexes in our kidneys. Some people might be more susceptible for these kind of diseases because of, again, for genetic issues, or maybe it's just something that over this kind of, when they were dealing with a viral infection, their kidneys became more susceptible to accept this kind of immune complexes throughout the infection. But with the fact that we know that these immune complexes are going to come and sit on your kidneys. And that's the reason that we can diagnose IgA nephropathy with a kidney biopsy, because when we do the kidney biopsy, we're going to see the immune complexes, this kind of extra IgA complexes on the mesangium, and it's going to light up on the immunofluorescence. And that's the way that we're going to diagnose IgA nephropathy. So again, as I said, this extra immune complexes in the mesangium, it's sitting there on your kidneys. They feel like, okay, we are safe. Now we are sitting somewhere. We're not circulating in the blood anymore, so we should be safe. But your immune system is really smart, and they're going to try to remove these extra immune complexes from your kidneys as well. Because your immune system is just trying to help there, and say that if these immune complexes are going to sit on the kidneys for a long time, we're going to have a kidney disease in the long term, because it's going to cause fibrosis. This is an extra substance that shouldn't be on the kidney. So they're going to try to fix the situation. But at the same time, when your immune system gets activated, your cytokines are going to get activated as well. They're going to go up. It's going to cause more inflammation around that area. It's going to cause more fibrosis throughout the years. And that's how IgA nephropathy is going to cause kidney disease. And that's the reason that over years, for example, 20 years, you're going to see ESRD, you're going to see end-stage kidney disease, you're going to see the need for dialysis or transplant in your patients. Because after years of having this kind of inflammation and fighting with these immune complexes between your immune system and your kidneys are going to give up, you're going to have more fibrosis on the biopsy, and eventually you're going to lose your kidney function. So I love this picture, and I got it from the Nature Reviews. And this is comparing the north side of your glom to the side that you are dealing with IgA nephropathy. So as I said, in the setting of IgA nephropathy, it's going to be a lot of inflammation. You're going to have increased cells, because your immune system is going to try to send some cells to remove those immune complexes. So you're going to have a lot of fighting between the immune system and the mesangium of your kidneys. Sometimes, you're going to have increased blood flow to your kidneys as well, which can cause more pressure inside the glom as well. So as you see here, like you see a lot of cells, like that's the reason that when we do the kidney biopsy, we're going to have hypercellularity in the mesangium. So it's not like a fancy word. It's like just so easy to understand. I know that I'm going to have a lot of cells in the mesangium when there's a fight going on. I see soldiers coming from the immune system, and I have some cells inside the glom as well that they're going to fight against. So it's going to be really crowded. And so when you hear the word of hypercellularity in the mesangium, that just means that you have more cells fighting with each other. And then what else? Yeah, so in the setting of IgA, so because of this fight over years, you're going to see fibrosis. So if you repeat your kidney biopsy, for example, 5 to 6 years after being diagnosed with IgA nephropathy, you're going to see more dead cells here, because as I said, it looks like a war. So you're going to have some fibrosis, because eventually some cells are going to die after fighting against these immune complexes for months or years, and then that fibrotic tissue is going to stay in your kidneys, and your immune system is not going to be able to remove that. So stays there, dead cells in the kidneys, and the more dead cells that you have in your kidneys, eventually you're going to lose your kidney function, and you're not going to be able to filter as much as you were doing before, and you're going to need dialysis. This is whatever paper that you read about IgA nephropathy, they're going to talk about this 4-hit hypothesis about IgA nephropathy, how it happens. I put this algorithm here again because I love how they question why this is happening. Like the first hit, why this IgA, this galactose deficient IgA is just why we are making galactose deficient IgA all of a sudden. And then why, again, we have this kind of generation of antibodies against this galactose deficient IgA. We know that this is kind of a different kind of IgA, that our body is used to that, but our immune system is making it. And it just have like a really small detail different from our IgA. But the way that our immune system tries to remove it is kind of aggressive, and they act like they are dealing with a bacteria or a viral infection against our own IgA. So the amount of response that we see from our immune system against this type of IgA is questionable as well. And some people would say that maybe it could be genetic. Some people are just more sensitive to the type of IgA, IgG things that we make in our body. And even with a small mistake from our immune system, your body is just going to respond to that. And their immune system is just overactivated, and it could be just all genetic. But we don't know, and there are a lot of studies ongoing about why this is happening. And the more we understand about this, we're going to be able to offer more to our patients because we're going to have more treatment options. So what are going to be the clinical presentations? It's really important to know this part because honestly, I get a lot of referrals on these patients that they've had a couple of these symptoms in the past, and they've talked to their physicians in the past as well, but no one has picked up IgA on them. And when I do the kidney biopsy and when I see the damage, it's really late to offer a lot of treatments for them. For example, if they come to me and they've had IgA for the past 7 years or 8 years, it's so much different than a patient who started having IgA last month, right? I see a lot of fibrotic changes in their kidneys. They might have lost a lot of their kidney function if they've had this IgA for the past couple of years and no one have diagnosed them. So from our side as a physician, it's important to know these presentations, how our patients are going to present, and be able to pick up the diagnosis as soon as possible. So a lot of these patients, they're going to come in and they're going to say that they see blood in their urine. They might see it on and off, and they might, when they're talking about it, they might not make a big deal of the hematuria or the blood in the urine. Because they might say that, well, I was dealing with an infection, I was really sick, I had a lot of symptoms, I was coughing, I had fever, and then all of a sudden I just saw blood in my urine, which was 1 or twice, and then it went away. And I didn't see anything, so I think I just got improved by myself. So they might say that. The reason that they say that is that in the beginning, you might see more blood in the urine. But after that, you continue to have the microscopic hematuria that your patients are not able to see. But if you get a UA, you're going to see a lot of RBCs on the urine. So yeah, they might not see the blood in the urine anymore because they are past that kind of acute phase of dealing with that infection, and they're not just dumping thousands of RBCs anymore. But still, if you see on the UA 100 of RBCs, it's super significant and it really warrants a kidney biopsy. So a lot of patients are not that lucky as well. And from the beginning, they have microscopic hematuria. And if they're lucky to go to the doctor because of their infection and someone orders a UA for them as well, and someone picks up those RBCs and the UA and they refer to a nephrologist, they're just those lucky patients that they come really early and you can do the kidney biopsy. They might present with proteinuria. Some of them, they might have hypertension. And a lot of patients are just asymptomatic. So if they go to their primary care physician for their annual exam and they do a UA there, as it shows hematuria, and then they come to you and say that I don't have any symptoms, I don't have any swelling, I don't have any high blood pressure, and it was just picked up on my routine exam, and my PCP just ordered a UA as a yearly exam that I do, and we saw blood. Or here in the United States, if you want to apply for an insurance, or if you apply for like a specific jobs or something, they might check your UA. And then on the UA, they see hematuria. And then after that, they're going to send you to a nephrologist. So sometimes it's just accidental, and someone has ordered something for another reason, and then you pick up the hematuria. And there are going to be some rare presentations of IgA as well. For example, these patients that can show up as a nephrotic syndrome or rapidly progressive glomerulonephritis, meaning that about less than 10% of these patients, they might lose their kidney function really fast in less than a month. And they might come to the hospital, they feel really sick. If you're losing your kidney function over 30 days, you're going to have all the symptoms of advanced kidney disease. You're going to feel uremic, you might throwing up, you might be having a lot of high blood pressure, headaches, loss of appetite. So it's not something that can be missed. And then acute kidney injury is another thing that you just stop making urine, or you might be making urine and then your kidney function gets worse. You feel really tired. You don't feel like yourself. You go and you do like some blood works to see what's going on, and you find out you have acute kidney injury. And malignant hypertension is another thing that some patients, they might come in with really, really high blood pressure. You do some blood tests and you see a urine test and you see blood in their urine. Sorry. So how do we approach to IgA nephropathy? This is an algorithm from KDIGO guidelines. The KDIGO guidelines are the guidelines that we nephrologists, we go back to KDIGO guidelines a lot to see what's the guideline about, the current guidelines about the diseases that we are dealing with. So when you're dealing with IgA, first of all, you have to think about the secondary causes of IgA. For example, you have to rule out IgA vasculitis. You have to think about other things. For example, if you're dealing with liver disease, like your patient has liver cirrhosis because of alcohol abuse, or even if it's NASH and it's not because of alcohol, anything that leads to cirrhotic, like cirrhosis patients, like they can have extra IgA on their kidney biopsy, and they can present as an IgA nephropathy patients. That's the reason that here, when we see hematuria in cirrhotic patients, I see a lot of pre-transplant patients that they are cirrhotic, they are waiting for their transplant, and they have some hematuria in their urine. And urology says that, well, it's not coming from their bladder, and it's probably like maybe IgA. We don't do a kidney biopsy because we know that if we do the kidney biopsy, we're going to see some IgA deposits on their kidneys, and it's common in the setting of liver disease, and it's going to cause misdiagnosis of primary IgA. We know that secondary IgA in cirrhotic patients is common, and we deal with that as a complication of cirrhosis. So the other thing is that sometimes hematuria can happen after an infection. It's not IgA nephropathy. It's called IgA dominant infection-related GN. This kind of GN is usually is resolved after a while. It's not like IgA, which is a progressive disease. And we have to be able to differentiate between these secondary causes of IgA versus primary IgA. So if you don't find any specific reason for the IgA, it's called idiopathic, or it's called primary IgA nephropathy. And then based on the kidney biopsy, we have a specific testing for the kidney biopsy, which is called MESC score. It shows how much damage has been done to your kidneys based on the things that we see on the biopsy. And based on that, we're going to risk stratify our patients and see what else we can do for our patients. And then we're going to talk about the management here later. So for the diagnosis, I put these biopsy pictures here. I'm a fan of knowing about the pathology. I read a lot about pathology because I feel like as a nephrologist, I need to have a good understanding of what's going on the kidney biopsy and not just relying on what our pathologists tell me. And I should be able to read that as well. And I think that if you're gonna deal with IgA, you need to know exactly like at least the basics of the biopsy as well. So what we talked about the IgA so far, we talked about the 4-hit hypothesis, right? So I told you guys that in the setting of IgA, the first hit is that you're gonna just make some abnormal IgA, which is galactose deficient. Then your immune system is gonna try to remove that galactose deficient IgA, and it's gonna make some antibodies against that antigen. So after producing those antibodies are going to go after the galactose deficient IgA, and they're going to make an immune complex. Once you have the immune complex, it's going to come and sit on your mesangium in your kidneys, and then you're going to have more response from your immune system because your immune system is going to go after them and they're going to try to remove them. And that's the reason that you're going to see a lot of cells in the mesangium. Now we are looking at the real biopsy here. And when I'm talking about the hypercellularity and mesangial proliferation, these are the things that I'm talking about. These blue cells that you see, these are the cells that you see more in the setting of an inflammatory status. So a lot of cells here, you see hypercellularity and you see proliferation. Proliferation means that your mesangium is just expanding because you need to expand and you need to have the proliferation in order to accommodate these extra cells, right? Compare this to a normal glom. So here, nothing is happening. Everything is normal. So you should have some cells, but you don't have a lot of cells in one area. For example, here you see 1, 2, 3, 4, and that's it. And this area is kind of not crowded. It's all pink, no cells. And then you come here, 1, 2, 3. It's like all pink here. So it's like calm and nice and some cells, everyone's working. It's like a normal state. And you compare that to the IgA, you see 1, 2, 3, 4, 5, 6, 7, 8, just 8 in one area and some pink area. And again, you have some cells here. So definitely more crowded when you're comparing it to this side, for example, right? So something is happening. As soon as your pathologist opens this kind of a slide, he's going to say, wow, a lot of proliferation and I see a lot of hypercellularity. So definitely not a normal kidney and we have to see what's going on. So if you see a lot of, if you are dealing with an RPGN patient, this is not RPGN, but you're gonna deal with a lot of more inflammation even in your arteries as well. And you're gonna see even more cells, you're gonna see more inflammations as well. So basically, and what I'm trying to say that the more your immune system responds to these kind of immune complexes, you're gonna see a more crowded biopsy here. But if you want to compare it to advanced disease, so this is the time that your immune system and your body is still fighting against those kind of immune complexes. It's acute phase. After years and years, your immune system is going to get more tired, as we said. They're going to send more cells. They're going to lose a lot of their soldiers here. So you're going to see a lot of blue areas in your biopsies, which means fibrosis. So in advanced disease, you're going to see a lot of fibrotic tissues on your glom as well. We have some advanced imagings of the kidney biopsy now, and we do the electron microscopy. This is the electron microscopy. It's important to know that in the electron microscopy, you have the immune system, these immune complexes sitting here, right? And you are able to see them. Like all these dark areas that says D means deposits, these are not normal. So you shouldn't see these things. So compared to this, look how clean it is. Yeah, like you see the GBM here, and you see the epithelial cells. and like nothing is so crowded. And in the setting of IgA, you have all these extra deposits sitting here. These are all those immune complexes that I'm talking about. They shouldn't be here. And that's the reason that your immune system cannot tolerate that. Your immune system wants to see it really clean and normal, and they're going to try to clean this area, which is not possible. And then we have the immunofluorescence microscopy as well, meaning that we have some special kind of coloring of the kidney biopsy that we do for different kinds of like the components of immune system. So for example, you can look up for C3, C4, IgA, IgG, IgM in the kidney biopsies, and it lights up and it shows that you have extra IgAs in your kidneys. Sometimes it can light up for the IgG as well, because in the beginning, I told you that you might have the increased production of IgA and IgG at the same time. So it just shows you that, yes, that's true. You are thinking about IgA nephropathy in the setting of hematuria, AKI, and or without AKI, just hematuria. And then you saw some deposits on the immunofluorescence, on the electron microscopy. You saw hypercellularity on your kidney biopsy, the mesangial expansion. And now I'm lighting up, I'm showing you that all these things that you're seeing on the biopsy is IgA. So this is gonna help you with the diagnosis. It's easy when you see it's lighting up and it shows IgA on the microscopy. So you say that it's probably IgA nephropathy based on what I found. You might see some extra things. You might see some IgG and C3, and that actually is going to backing up your diagnosis of IgA, because it's common to see some C3 and IgG in the setting of IgA nephropathy. I told you about the MESC score. You don't have to know about that, but there is like a table about that, and your pathologist is going to go over this table. And that's the reason that when they are reporting the MESC score to you, it's based on this table and how much damage has been done to your kidneys. So, and now we're going into the treatment. So any questions so far?
There are some questions in the chat, Dr. Norouzi. Do you want to go over those now or at the end?
I see some questions about the treatment. So I'm going to talk about all of these options just right now. So let's just go over these questions later on, because I'm going to answer most of them. So I see a lot of questions about sparsentan and these treatment options. It's amazing. Yeah. So let's talk about them. I'm happy that there is some interest about these medications. So there was a paper on JSON, which is one of the most prestigious journals that we have in nephrology. And they focused on IgA nephropathy, and the question was that, is there a minimum duration of proteinuria remission that is associated with improved outcomes in the IgA nephropathy? And the answer is yes. The more that you can keep your patients on remission, like the more time that they have on lower proteinuria side, you can reserve their kidney function for a longer time. So it's important to keep our patients in remission, and it's important to focus on the amount of proteinuria in the setting of IgA nephropathy. So proteinuria is a prognostic factor for us. If you see a lot of proteinuria, meaning more than 1 gram in your patient with IgA nephropathy, it has been linked to higher risks of going on dialysis later on, or needing for a kidney transplant. So that's the reason that is an accepted endpoint for us in clinical trials. We look at the proteinuria as a success factor. For example, if I have a patient with proteinuria of 1.5 grams, and I start treatment for my patient, and then proteinuria comes down to less than 1 gram, that's a success for me and for my patient, because I know based on the research out there, the less proteinuria my patient has in the setting of IgA, the less risk of going on dialysis later on. So the treatment that KDIGO right now, our guidelines are suggesting, is that we're just gonna try to keep the blood pressure less than 120. So we're gonna control your blood pressure as much as possible. And we're going to start you on RAS inhibitors, meaning, for example, lisinopril, losartan. So that's going to be our first line antihypertensive. I'm really aggressive about how much losartan and like ACE inhibitors I give to my patients or ARBs. And I'm really aggressive. I actually go up to the point that my patient says that I feel like sometimes I feel dizzy and lightheaded, and I'm not able to tolerate more than this. And that's the point that I'm going to stop on increasing ACE inhibitor or ARBs for my patients, because there are a lot of studies that shows that ACE and ARB can prevent and can actually bring down the proteinuria in IgA nephropathy patients. And I want to control their blood pressure as well. So I have good reasons to start this medication and up titrating the medication to the point that it's a maximally tolerated dose. It's the best practice that you can adopt. And then you talk about the lifestyle modifications, weight loss, exercise, not smoking, trying to restrict sodium, everything that we talk to our patients when they're like other patients, CKD patients that come to the clinic as well. And then you're going to try to adjust the cardiovascular risk factors as well, because IgA nephropathy patients are going to be at higher risk of having cardiovascular events. I love this summary. It shows a lot of options for our patients. So we talked about the blood pressure reduction. We talked about ACE and ARB. SGLT2 inhibitors are almost the newer agents that we have for IgA nephropathy. On the DAPA trial, they looked at the IgA nephropathy patients. There was a subset of IgA nephropathy patients that they received SGLT2 inhibitors, and it showed that actually it's going to decrease proteinuria in these patients as well. So we start SGLT2 inhibitors for our patients early on after starting ACE and ARB. And then you have the option of sparsentan that we're going to talk about it. We told you about the weight loss, smoking cessation. We're going to adjust we're going to check the lipid panel for these patients. And if it's needed, we're going to start them on statins. The fish oil is controversial. If they have to take the fish oil and they've said that they want to try fish oil, it's not the normal dose. If you give them just one capsule a day, it's not going to work, and requires a really high doses of fish oil, which means 3 to 12 grams, and usually towards like the 10 grams, which means about 10 tablets a day. And fish oil tablets are really big. So it's going to be a conversation with the patient if they want to take that many pills. Tonsillectomy is another option, but the studies have been only positive in Japan, and they've been doing that for our patients with IgA nephropathy in Japan because they've been seeing positive results, but nothing positive in the United States. I do not recommend tonsillectomy for our patients here. So now we have the sparsentan on this table, and we have some newer options for IgA. So we're going to dive into that. But before that, we're going to say the steroid. We have a lot of studies on using prednisone and steroids for IgA nephropathy. First study started in 1997. It's been a long time that we are using a steroid for patients with IgA nephropathy. It was the only agent. Sorry, guys. It was the only agent that we had for IgA nephropathy for proteinuria more than 1.5 grams. And it was recommended on the KDIGO as well, which was suggested on the KDIGO guidelines. I'm not a fan of prednisone for our patients. It comes with a lot of side effects. You can have high blood pressure, diabetes. For younger patients, acne, it's important on their skin, and then a weight gain, changes in your mood, and having being susceptible to a lot of infections. Once you start high dose prednisone, you have to start antibiotics for PCP prophylaxis. You have to start PPI for acid reflux, and you have to start vitamin D and calcium. So it comes, it's like a package, and your patient all of a sudden they have to start a lot of medications. If I have other options for my patients, I try to avoid the steroid in the setting of because of all the side effects. Not for IgA, for most of my GM patients in the clinic, if I have other options, I try to avoid prednisone. Okay, so now we have new medications, we have clinical trials, meaning that we have more options for our patients. What options that we're going to talk about, we have SGLT2 inhibitors, we have sparsentan, we have the option of enrolling into clinical trials, and we have the targeted release budesonide. We're going to talk about this is the SGLT2 inhibitor study that we talked about. We're going to talk about sparsentan. Sparsentan is a non-immunosuppressive medication that is a dual endothelin and angiotensin II receptor antagonist and has a high selectivity for the ETA receptor and angiotensin II subtype 1 receptor, AT1 receptor. So as we said, it's a non-immunosuppressive, which catches my eyes because I feel like we suppress the immune system too much sometimes in the setting of GN disorders. As we said, we've been using steroids for a long time. So that's something that is interesting to patients and physicians. And this medication got the FDA approval recently. It had the accelerated approval, but whenever we hear accelerated approval, it means that pending some conditions in the future, and they have to do further studies to see if it comes back positive in order to preserve the GFR in long term as well. But their study was positive for the for reducing proteinuria in patients with IgA nephropathy. So they have ongoing studies going on the sparsentan and effects of sparsentan on the GFR. But right now, how we start the sparsentan, it's a tablet that we start with 400 milligram daily. The 400 milligram target, it's at the target dose, but we start with 200 milligram daily. The caveat for the sparsentan is that you're going to need to monitor the liver enzymes. You have to check the liver enzymes really frequently every month for the first couple of months, I think, for the first year. It's a lot of blood works for the patient. And you start with 200 milligram daily. If your patient is tolerating the medication, you're going to go up to 400 milligram PO daily, and you continue the medication. It's considered the first in class due to dual blocking activity. As I said, the study was positive for reducing the proteinuria in patients, and that's called the PROTECT study. That's the reason that because of the amount of reduction that they had in the proteinuria, they got the FDA approval. The good thing about the PROTECT study is that in this study, they had patients from different races. So unfortunately, a lot of studies that we have in IgA nephropathy is focused on Asian patients. But in this study, they were really diverse, and I think it's really important, because if you only focus on a specific race, for example, whites, Asians or something, then we're not sure if it's going to apply to other patients as well. But they had 53% of patients from Europe, 27% from Asian patients, and 20% from here, so from North America. So a very diverse group of patients, and that's honestly a good point about their clinical trial. Then we have another option. We have the targeted release budesonide. It's another new agent that came in to treat IgA nephropathy. It's still considered steroid, but the good thing about the targeted release budesonide is that this medication only delivers the drug to the distal ileum in order to decrease and minimize the adverse effects of the prednisone. Because, you know, when you're taking prednisone, it's just going to get released as soon as you take it, and it's going to be a systemic medication. The targeted release budesonide, it doesn't get released until it gets to the distal ileum, and we think that the distal ileum is one of the targeted areas that makes a lot of galactose deficient IgA in the setting of IgA nephropathy. So it doesn't get released until to get to that target, and then sits on the receptors and starts releasing the medications. So the NefIgArd trial that everyone has been talking about it for the past 2 years, It was a randomized, multi-center, double-blinded, and placebo-controlled medication trial. They had biopsy-confirmed primary IgA in these patients, and patients had more than a gram of proteinuria. So one thing about the clinical trials for IgA nephropathy, all of the patients that they get enrolled into the clinical trial should be biopsy confirmed, because otherwise we cannot assume diagnosis when we are trying to try a new medication and say that proving that medication works for IgA nephropathy. They have excluded patients that they had history of kidney transplant, or if they had uncontrolled cardiovascular disease and they had severe GI disorders, liver disease, or diabetes, or current history of malignancy within the past 3 years. So their study was positive in terms of reducing the proteinuria as well. At 9 months, they had 25% reduction in proteinuria when they were comparing that to placebo. And 12 months, they had 48% reduction in their proteinuria, considering when they compared that to the placebo group. And then they had positive response in GFR as well. Their data just came out recently, and it showed that it's going to preserve the GFR as well. It's a tiny amount though, like it's only 3 to 4 cc per minute of the GFR, which is like when you're checking labs, might not be that significant to you as a physician. One thing is important to me is that when I'm starting these medications, if I see the proteinuria is coming down and then kidney function, at least it's not getting worse, it's just the same, that's a good sign. It shows me that I'm suppressing that kind of I'm suppressing the immune system, and actually I'm probably going to be able to prevent the progression of disease for my patient. So in summary, we used to tell our patients, change your lifestyle. You have IgA, go home and try to eat healthy and exercise. And the best that I can do for you, I'm going to start you on some ACE inhibitors and ARB. But it's changing. And I was telling one of our residents in a clinic, it's an exciting time for IgA nephropathy. I know it's such a nerd thing to say, but it's exciting because it's not just about the new medications coming out. We have a lot of clinical trials ongoing for IgA as well. We are actually site for 2 clinical trials, and these complement inhibitors are sounding promising as well. And that's another option for the patients. Now we have a lot of options, like when the patients with IgA, they come in, I have 2 newly approved, like FDA approved medications for them. I have sparsentan and I have the budesonide for them. And I have a lot of clinical trials out there that they sound promising. And so I have a really long discussion with my patient. It's really rewarding to me as well. I hate to go in and as a doctor and tell my patients, well, just go and fix your diet and good luck. And this is the medication. This is one pill that I can give to you. Now it's so rewarding that I can give them a lot of options and they can decide. Now, as the new generation physicians, what is our responsibility? Is that to question the current guidelines. When is it exactly the best time to start treatment for IgA nephropathy? Should we wait until the proteinuria is more than a gram, or should we start it as soon as possible, even when you see some protein, not more than a gram, but maybe 500 milligram of proteinuria? Should you start medications at that time or not? Or should we do combination of medication? Should we do sparsentan with a long-acting budesonide at the same time to target different areas and try to decrease the risk of going on dialysis and getting transplant in the future for our patients? These are the questions that we need to answer. Now we have different options, and I'm sure that it's going to get more complicated once these clinicals are done and we have the complement inhibitors. And then we have to think about, like, should we start the whole package for the patients, or should we start the complement inhibitors? Should we just go with budesonide and wait and see what's going to happen, or sparsentan? It's exciting. I'm happy that a lot of research is ongoing with for the IgA nephropathy. And I think everything starts with having a good understanding of what happens when we get IgA. And I feel like because of a better understanding that we have these days, clinical trials are going after different steps and are trying to target different steps of IgA nephropathy. And hopefully we can actually at some point say that we have a cure for IgA nephropathy for our patients. Well, thank you so much for listening to me. And now I'm ready to answer your questions.
Thanks so much, Dr. Norouzi. This was actually very helpful, especially because there are so many new treatment options for IgA. So that was great. Okay, I know we went through some of the questions in the chat, but there's some more that came up. So the first one was, in IgA nephropathy with low C3 means activity of disease and treatment with immunosuppression or infection associated with IgA and treatment with antibiotics.
So if your IgA is secondary to an infection, when we went over the algorithm of the KDIGO guidelines, let me show you this algorithm. Here. So we said that like in the beginning, we have to rule out the secondary causes of IgA nephropathy, right? And one of them is the IgA dominant infection related GN. So if you think that this is IgA dominant infection related, and then we have to treat the infection first, right? Like, for example, if it's a bacterial infection that's been ongoing for a long time, then we have to treat that bacterial infection and see if IgA is gonna improve. That's the way that you're gonna rule out that thing, because if you are dealing with this kind of prolonged bacterial infection, then probably it's gonna be because of that. If you don't find any specific reason, for example, patient has recovered completely from the infection and they're still having hematuria, that probably you're dealing with primary IgA and you want to start other treatments, like you want to treat the patient as an idiopathic IgA nephropathy.
All right, perfect. Thank you for that. The next one was Barsantan improves proteinuria in focal segmental, but so do we use that in IgA nephropathy too?
Yeah, exactly. So sparsentan, sorry.
No worries.
Sorry, my kids give me like all kind of viral infections these days. So sparsentan, yes, that's true. It improves the proteinuria, but not the GFR. That's actually so accurate, and the data just came out about the GFR in FSGS. In IgA nephropathy, we know that sparsentan reduces the proteinuria, and that's the reason that FDA approved the medication. The study on the GFR is ongoing on the IgA. The data is not out yet. And probably I was talking to their company the other day, and they told me that probably their data is going to be ready around the ASN time, which is going to be October, November, something around that time. But we don't have the GFR data in IgA nephropathy yet.
Perfect. Okay, I want to make sure that we get some questions. There's a lot of questions for you. So, but Cameroon team, I want to make sure that you guys have a chance to ask some questions too. So feel free to unmute. I think I see one in the chat from you guys, so I'll read that. And then if there's more, feel free to jump in. But in low middle income countries where we rarely perform kidney biopsies, how are we confident that we can make the diagnosis of IgA nephropathy when faced with a patient who clinically presents with features consistent with glomerular nephritis like hypertension, hematuria, proteinuria, etc.?
That's a really good question. Sometimes even here, like kidney biopsy is not possible to do because there are some contraindications for the kidney biopsy. For example, a patient has a single kidney, or their kidneys are really small, or something like that, that you just don't feel comfortable about doing a kidney biopsy, and you have to diagnose your patient based on the clinical presentation. If your patient is so obvious, like you don't have any other reasons, the history that your patient is giving you towards IgA nephropathy, you see the hematuria on the urine. If you have access to urine microscopy and you see the dysmorphic RBCs on the UA as well, then you have enough reasons to treat the patient as IgA nephropathy, because if you don't treat these patients, they're going to end up on dialysis, right? So if everything is towards IgA, even if you're not able to do the kidney biopsy and say for 100% is that's the IgA nephropathy, treat it for IgA nephropathy. We have some patients here as well that sometimes even the patient refuses kidney biopsy, and then everything is towards IgA nephropathy, and you start them on treatment.
Perfect. Yeah, that's a very good point. It's always like that's when the clinical diagnosis and observation comes into play. Okay. Anything else, Cameron? Feel free to jump in. In the meantime, how and when to withdraw budesonide is the next one.
Oh, yeah. So it's actually interesting. So you know what? When you start a steroid, when you start prednisone, the tapering of the prednisone is another process by itself, right? Because you cannot stop prednisone all of a sudden. So for example, you're giving 50 milligrams of prednisone to your patient, and you want to taper it down, and there is no specific guidelines about it. Some people go down by 5, some people go down by 10, and the amount of days that you are on, like when you're tapering, depends on different practices that you have. And I have different people, like I have like a nephrologist here that tapers around like in 2 or 3 months. I have another colleague that tapers down in 1 month. So a lot of different practices, but again, you cannot stop the medication overnight. For long-acting budesonide, when you want to taper down, you treat the patient with 16 milligrams of long-acting budesonide for 9 months. It's taking 4 tablets in the morning before the breakfast. And once you're done with the 9 months, or a patient is responding and you want to taper it down, you go down to 8 milligram in the morning, like which means 2 tablets before the breakfast in the morning for 2 weeks, and then you're done. You can stop the medication.
Excellent. The next one, if I know it's 8:02, so we have a couple options here. I want to be, I want to make sure I'm respecting your time as well. Should we keep going, or do you want to take these via email?
Yeah,
okay.
I can take a couple of more questions. Yeah.
Excellent. So this next one is why rituximab failed to improve IgA.
Yeah, we cannot say like these medications they're going to like studies, and we don't do rituximab. But you know that rituximab is the B cell, right? Like a suppressor. Maybe in the type of like IgA vasculitis, you might try rituximab. But nowadays that we have these newer options, which are safer, we don't use rituximab anymore. Even before that, the options that were recommended based on the guidelines was if your proteinuria is more than 1 gram or 1.5 grams, we were going with the prednisone, not rituximab, unless your patient is not responding to that. They have RPGN, they show that they have IgA vasculitis. So at that time, we were trying rituximab. So, rituximab is not a medication that you just start for the IgA nephropathy that you saw some hematuria, some proteinuria. It sounds too much to suppress immune system that much in starting an infusion like rituximab. So it was never a medication that was really hot for IgA nephropathy, but I've used it for my patients with IgA vasculitis in the past and patients that they've had RPGN.
Okay, that makes sense. Absolutely. Okay, I think Cameroon, they were having some connection issues, so that's probably why they just dropped off. Maybe just this last question, I think is helpful, and so it'll be on the recording. These patients, so what about, so a lot of times these patients will present with a type 4 cardiorenal syndrome. So if they develop associated heart failure, can we use SGLT2, or are they contraindicated?
Yes, so SGLT2 inhibitors are actually being prescribed with by a lot of cardiologists these days as well. I think because of the effects of SGLT2 inhibitors on the proteinuria and decreasing the risk of cardiovascular events in patients with proteinuria and CKD, I'm a fan of SGLT2 inhibitors unless we have an absolute contraindications for it. Even for the GFR, I know that the SGLT2 was not studied in the really low GFR if the patient has CKD stage 5 or so. But in real practice, to be honest with you, I've seen patients on SGLT2 with really low GFR as well. It's just because it shows a lot of positive effects in our patients. It decreases the intraglom pressure for our patients and decreases the proteinuria, decreases the risk of cardiovascular events. So I see a lot of like the practice is towards like pushing towards like using SGLT2 inhibitors instead of just finding a reason not to start it or stop it. So I think, yes, I would do that for my patients.
Excellent. That's actually really good information. I know a lot of people, it's a newer drug and we're seeing really good benefits from it. So it's nice to see that it's another option here. And I think overall, what we've seen today is that there's a lot more options for IgA nephropathy than what we maybe previously thought, or at least what I previously thought in my limited knowledge as well. So that's excellent. So I think that's good for the questions we have now. If there were any unanswered questions, you can feel free to reach out to us at Health for the World, and Dr. Norouzi, I can forward them to you as well. So then people can follow up with any other questions that they may have. But I think this was a really good topic, and thank you again for coming. Every time you come, it's always a good topic. It's always a very high yield topic. Something new, cutting edge is also discussed. So we really appreciate having your expertise on the subject, and hopefully we see you again soon for another nephrology lecture.
Of course, thanks so much for having me. I had a great time. Thanks for the great questions as well. You can email me as well if you'd like to share my email, or you can find me on Twitter to ask questions. Really, like, I love to talk about IgA, so feel free to reach out and ask questions.
Absolutely, yes. Okay. Take care, everyone, and we'll see you in the next one.